Hey folks, good morning. I'm going to give this talk titled Mastering ABOS Part 2. I'm giving this in the fall of 2022, and we'll focus on logistics, tips, and tricks that I've learned over the last 2 years. Who am I? I did med school at Pittsburgh, residency at Vanderbilt, and did 2 fellowships, and I stayed on faculty at Emory after finishing my joints fellowship. This talk is targeted towards folks that are in the first year of practice. It is helpful for current fellows as well. I think the best way to utilize this talk is to be able to see it before you start practice. But it's certainly helpful to people who are either in board collections or are about to go to Chicago. And then this talk is also going to be helpful for people who have unfortunately failed the first cycle. If you are a DO, the certification process for that is separate, and that will not be covered here. Also, I'm not going to share any actual questions my examiners asked me. That's keeping in line with ABOS policy. But I've done my best to try to make hypothetical scenarios that are similar to what I experienced. Why give this talk? I think there's no clear guidance on this exam right now. The impact of failing is going to be significant, certainly personal on you as a surgeon and second guessing yourself. And then professionally, whether that's the amount of cases you take on or how the hospital views you. It's going to be a tough year if you do fail. And I don't want any of y'all to have to go through that. So that's why I've come up with this talk. Outline of this talk is I'm going to first talk about my experience only as much as it relates to helping you guys, and then timeline and logistics of the actual exam. We'll go over that as well. And then tips and tricks, kind of what to do right as you start your practice, what to think about when you're in case collections, and then how to prepare your 12 selected cases. And then I'm going to mention this over and over again during the course of this talk, but the delivery and presentation of your cases is just as important as the actual cases themselves. And so we'll go over pearls and pitfalls on the day of the exam itself. And then finally, the section at the end that can help address how to prepare for round 2 in case you didn't pass the first time. Failure is uncommon, but it is increasing. If you notice just this last cycle, it was a failure rate of approximately 17%. That's higher than any other year pictured on this exam statistics table. This is directly from the ABOS website. So having 141 folks fail this exam last year is a scenario that we want to try to prevent for everybody involved. There's little guidance on how to take this exam. And remember, the folks that are taking this exam are highly motivated, accomplished, smart individuals. So if you have nearly 150 of them failing, then this is something that needs to be taken seriously and prepared for. Briefly, my journey, I thought I was a good surgeon with reasonable documentation. I had reasonable indications. I thought I worked at an academic center. I prepared for the exam best I knew how to, and I did prepare. I didn't not prepare. So I read articles. I tried to read primary source literature. I read 3 to 4 articles on each case that I had, and I presented my case to my 4 partners who were all really well trained as well. And then I read some literature, like I said, and then I cleaned up and I went to Chicago. Here are some of the cases I went to Chicago with during my first cycle. Here's an example of a 66-year-old with a transverse patella fracture. I fixed her with a tension band technique. Here is a stable intertrochanteric femur fracture in a 77-year-old male that I treated with a short nail. And then here's a 61-year-old lady that I had primary varus knee osteoarthritis that I treated with a primary total knee replacement. And if you want to look at all my cases, you can come to Emory Spine and Joint Hospital. There's the EUWASH library, and I've left a box with all 12 of my cases there. Should anybody have any questions about what I did or how I did it, just return them at the end of your investigation. And then I waited for my results, and then I found out I failed. because you get this letter. It's kind of long. The fourth word says regret. And so you don't need to read the rest of the letter to understand what happened. So you're at the launch pad of your career, and, it is like a shuttle exploding right on the launch pad. And there's no real feedback on what happened, why it happened. So it's very frustrating. Here's the timeline of events. I started my job in 2019 in the fall. And then I collected in my first April to October, which was 2020. And then I sat for the exam in 2021. So basically 2 years after you've started your job is when you're going to go and sit for the exam. You'll find out that same year whether you passed or failed. And then here's the point I want to get across. In the year that you fail, that's the year they're going to go back and collect cases from. So you may or may not even be in the mindset that you're collecting cases in April to October of 2021, because why would you? You thought you were done with collections at the end of October or in 2020, right? So you thought case collection period was April to October 2020. You were done with it. You kept doing cases. Maybe you got a little more cavalier. Maybe your documentation suffered even more in 2021. And then when you find out you didn't make it in 2021, the board is going to pull cases from 2021. My advice here is, unless you actually really get a letter in your hand that says you've passed, think of yourself as always being in collections. When I went back for round 2, there's a new set of cases. I was told I was going to get a new set of examiners. I did get a set of new examiners. However, I had a close friend who went back for his second round, and he did not get a set of new examiners. Some of his examiners were the same from the previous year. If your scenario and you have talked to the board about getting new examiners, make sure that you raise a conflict of interest when you see the same examiners again. And then folks worry about, well, how many of my cases are going to have complications? Well, I'll tell you, the second time I went back, I had 10 out of 12 cases which were picked, all had complications. Here's an example of some of the cases I went back with my second year. Here's a lady that had a pelvic discontinuity in the setting of metallosis that I treated. There's a morbidly obese 46-year-old who was sent to our tertiary care center with pelvic discontinuity and horrendous prosthetic joint infection. And then here's another prosthetic joint infection after a front back ORIF, and I treated him with I took all that stuff out, put an antibiotic spacer. Couldn't take that front plate out because it was right underneath the iliac vein. Here's another case, morbidly obese, unstable knee that was also infected that I treated. And my point is, you can fail with very simple cases, as you saw in my first go around, and then you can pass with very complicated cases. My word about folks taking on complexity is complexity will bring more complications, potentially, and you need to be able to defend the decisions you've made. If you've taken on a very easy case, the chances are you will not have to make very many complicated decisions, and those can easily be defended. If you take on more complicated cases, that opens you up to more scrutiny. You're going to have to make more decisions in those cases because they may come back with a dislocation, an infection, etc. And then you have to make more decisions. And then each of those decisions you've made in the care of that patient are scrutinized. So if you feel confident in your ability, then take on complicated cases. If you don't, then my advice is don't take on complicated cases. Your preparation and delivery is also very important, not just the complexity of cases. How you polish them up and how you show up on that day in July is going to be very important. My general thoughts, you could be the best examinee in the world, very knowledgeable, and you could be Da Vinci with your own hands, but you can easily give the appearance of someone having poor judgment because you're flustered. And these examiners don't know you. They have a very short period of time, about 30 minutes in that room with you when you're extremely stressed. and they're going to probe your knowledge and look for holes. And this is a type of stress test. And so if you get flustered or are not well prepared, then that's all they have to judge you on. So it's very important. No one case by itself is going to fail you. We all have tough cases and tough days. The board recognizes this. So if you have one horrendous case, provided that it's an expected complication, not something like you've completely cemented a stem outside of the femoral canal, no one case by itself is going to fail you. How do I think examinees fail? I think it's from systematic or additive errors. So let me explain that. Systematic errors are each of the 12 cases you have has a poor consent. That is a systematic error. And that is something that I think will downgrade you on every one of those 12 cases. And so if that's the case, it's a systematic error. Or additive errors. So you're sitting in there, you show a case, they say, why'd you do this particular total knee arthroplasty? And you say, well, I am a consultant for this company and that's why I did it. And then you say, wait, so now you're a consultant. And so then they say, well, why are you adding these additional stems on this total knee? And then you say, well, I've added them on because I think the patient had osteopenia. And then you look at the bone and they're like, oh, well, I see here that you submitted that their T-score is actually not osteopenic. So why are you putting these stems on? And then you are flustered again and you keep making up horrendous answers to horrendous questions. Or actually the questions are not horrendous, and then these are additive errors where you're digging yourself a hole. And as you dig yourself a hole, it's going to, the first thing you need to do when you're at the bottom of a hole is stop digging. And I think additive errors are when they ask you one question, you give a poor answer, they probe you on your poor answer, you give it another poor answer, and then you keep giving poor answers, and then your helicopter is headed to the ground. The process, here it is. First, you take ABOS Part 1. That's at the end of residency. I think all of us have probably done that. And then you start your first year of practice. The cases are collected in April to October, and that's a 6-month case collection period. So all cases you do in that 6-month period get submitted to the board. And then the board takes that entire list and picks 12 cases that they think they want to examine you on. A human will pick those 12 cases. This is not a computer-generated process. And then for those 12 cases, once they let you know which cases those are, you have to go back to the board and give them all the detailed documentation for all 12 of those cases. And I'll outline exactly what those are. Then in July of your second year of practice, you go to Chicago and you present those 12 cases in person. So, here's the letter that I'm sure everybody's gotten. You pass your first part 1 of your boards. And then after completion of your fellowship, you have 5 years to take part 2. You're going to take the exam in July of a given year, but the 17 months prior to sitting for the examination, you have to be at the same job. So if I started at Emory in 2019, then I can go sit for the exam in July of 2021. And if I'm moving around jobs, then the clock resets. So you have to be mindful of that. Also be credentialed at your job before November 1. This is in the fine print of ABOS Part 2 in order to be able to sit for the exam 2 years later. If you're not, your timing will get pushed. So be credentialed at your job before November 1. Collection period, again, April 1 to October 1. This is a 6-month period. If you decide that you want to game the system and take a lot of vacation, well, if you're away from your practice for more than 14 days consecutively, then they're going to back up your case collection period back to March 1st. So then you'll be collecting from March 1st to October 1st. So also, if you've needed to take leave for more than 30 consecutive days, then you have to just call the ABOS office, and they may make a decision about whether they want to let you sit for that cycle or not. You need to do a minimum of 35 cases. And just as reference, my first cycle I did 161. My second cycle, actually, I had even more than that. You need to be the attending of record. on those cases. If you've done cases with a co-surgeon where you did not do the majority of the case, those cases don't count for your 35 cases. Here is the rubric. I'm going to pause here for a second. This rubric is on the ABOS website itself. This is what they grade you on when you are presenting. And you ideally want to be in the blue column all the way on the left above expected level. And then the reverse is true. Don't want to be on the purple side. Things that they're going to look for are data gathering, how you diagnose and interpret that data, what your treatment plan was, what your indications for surgery were. They will grade you on technical skill. So you may have complications, but those have to be expected complications. If you're in there cutting the sciatic nerve on a hip replacement, that's not really an expected complication. That's that is very tough to explain versus having a calcar crack. That is an expected complication. They'll also judge you on your outcomes. And so I'll go through most of these portions of the rubric in the slides to come. Also pay attention to ethics and professionalism. That's not always a gimme kind of category. If you've got poor billing practices, if they ask you questions and you don't have sharp professional answers for these, or you're giving poor answers, this is a category that I know some people have not done so well in. During case collections, you're going to log all your surgical cases into an online platform. Okay, in that online platform, for each case, here's what they're going to ask: your ICD-10 code, your CBT code for the case, and if there was a complication. If you check yes, there was a complication, there's a drop-down box, and it's going to ask exactly what type of complication it was, whether it's DVT, PE, infection, non-union, loss of reduction, death, etc. And then there's a separate online platform at the same time where you will submit patient email information. The board collects the email information of the patient so that they can send out patient-reported outcome measures to the patient. As of my cycle, the board was not very strict on collecting patient-reported outcome measures. However, this may change at a future date. It is always in your benefit to have more information and be more prepared for the exam than not. During case collections, I was told that you need to document well, and that's all I really got. That was the advice I got. I'm gonna help you guys here a little bit better. Your documentation has to make a case for why you did surgery. That is a better way to explain it. In your documentation, instead of saying patient had knee pain that was 2 out of 10, and we decided to do a knee replacement, that is an example of poor documentation. You need to, in your pre-op clinic visit, you need to make a case for surgery. The patient has 10 out of 10 pain. Patient has failed a corticosteroid injection, physical therapy, NSAIDs, RFA. And the exam shows pain along the joint line of fusion, patellofemoral crepitus, and limited range of motion. You're making a real strong case for why you need to do surgery. And then the obvious part is true too. Documenting well includes a good HPI, good past medical history, review systems, medications, allergies, and then a good physical exam that is objective. If you just put good range of motion, that is, not great. So in a very objective goniometer type based exam, at least in the arthroplasty world. And then in your assessment and plan, which I hope you dictated, detail the risk, benefits, and alternatives clearly. So I discussed non-operative management with the patient, which the options included continued physical therapy, weight loss, and injections. And then the patient was unwilling, had already tried X, Y, and Z, and was not interested in any further non-operative management. Therefore, we decided to proceed with a total knee arthroplasty. If imaging is pertinent, comment on it and obtain it. This is Kellgren-Lawrence grade 4 osteoarthritis of the knee, where this is a displaced, unstable intertrochanteric femur fracture. And make sure you obtain imaging. If you just have one poorly shot oblique of your hip, and then you decided based on this view that you were going to do a total hip replacement, well, just imagine sitting there in July and them saying, is this the only view you have? Anything written on your clinic exam is fair game. So if you're doing some sort of procedure on a rheumatoid patient and on their med list, it has Humira on it, the board examiners may look at your clinic note and say, wait a minute, this patient was on this medication. What did you do? Did you stop it before? When did you restart it, et cetera? So anything on that piece of paper is fair game. So make sure you look closely at each paper you are submitting. Data gathering. So this is sort of one of the earlier parts on the rubric. Data gathering says you've recorded a good history, a complete physical exam, and you've put down advanced imaging or any imaging, and you've interpreted it appropriately, including diagnostic studies. So if you're doing carpal tunnel releases, in addition to a well-documented hand exam, a 2-point discrimination in the median nerve distribution, have you gotten EMG studies? Yeah, just because you didn't get an EMG study doesn't mean they're going to put you all the way in the purple. But if you do have an EMG study, that certainly helps you look like a safe indicated surgeon. They're going to put you in the blue. So data gathering is very important. A good history, a good physical exam, and then making a strong case for surgery when it is indicated. If patients are coming with outside hospital records, make sure you get them scanned into your chart. Sometimes they come in and then they're thrown away, and then come board collection time or submission time, when one of those cases has been picked, you can't find those records. So make sure any kind of CDs or any imaging that comes with the patient is actually stored into your system come time to upload it for you. Here's an example of a case that I had, and this was a intra-articular distal femur fracture. And I won't go into the specifics of what I was asked here, but I would highly, highly encourage you guys to make sure, again, for each case, you document your operative option, and then you also document non-operative treatment options, regardless of how ridiculous that may or may not seem. So if somebody comes in with a displaced both bone forearm fracture, clearly document that you have discussed non-operative treatment options. You don't advise non-operative treatment options, but the non-operative treatment options include no surgery, and the risks of that include non-union, malunion, et cetera, so that you can demonstrate to the board examiner why you have done what you've done. Next slide is on surgical consents. The board treats this particular document very seriously. So they may pull it up in front of you and say, did you talk to the patient about the risks? Oh, yeah, you did? Okay, well, let's pull up your consent. What did you document here? Also delineate the alternatives and do your own surgical consents at the time of case collections. And I'm not going to comment on your practice, but at least to be a good, safe surgeon, if you are the one doing the consents, you can at least document the most pertinent risks and alternatives of each case. So they'll say, hey, you consented the patient for an MUA of the knee, and then you broke the femur, but nowhere on your consent does it say fracture, risk of tendon disruption, wound dehiscence. So did you not talk to this patient about this ahead of time? And another fair game question just maybe, while you're sitting there before the exam's even started, hey, Dr. Z, tell us about your consent process. How do you do this with your patients? Or do you consent them in clinic? Does your PA consent them? How do you do it? For folks that are at the academic centers, like myself, I would highly encourage you guys to not have your residents or fellows or PAs do these consents. I would do the consents yourself. Here's an example of one of my consents. And something I learned from the first cycle was practical alternatives to the procedure of a total hip replacement. No surgery is probably not good enough. You need to talk about limiting weight-bearing activity, physical therapy, weight loss, talk about injections, bracing, what have you. That alternative list there is insufficient. Again, anything your resident or your PA does is on you. If they're the ones documenting, you have to answer for it on the day of the exam, and blaming a trainee is a poor tactic and frowned upon. Next portion of the rubric I'm going to talk about is indications for surgery. Please do indicated surgery only. You're going to be coming out of fellowship. You're going to want to be busy. And sometimes your partners may back you up into a corner and say, hey, I can't do this. I'm out of town. Can you handle this case or whatever? Ultimately, you're going to have to answer for any surgery that has your name on it. When you're doing these elective type surgeries, make sure that non-surgical options have been discussed and tried. If they haven't been tried, have a reason for why they haven't been tried, and make sure that's documented. Avoid doing exploratory type surgeries like patient came in with a painful knee, wasn't infected, it wasn't loose, but we thought, well, maybe we could release some scar tissue. Imagine sitting in front of a panel of two very experienced orthopedic surgeons who are saying, you did what? And is there ever an indication to go in to release scar? And if you don't have literature to back that kind of thing up, it starts making you look like an unsafe surgeon. If you show up and you did a uni and somebody who's got a BMI of 50, and then they subsided, that's not an indicated surgery. The literature clearly supports that morbidly obese patients don't do well with a partial knee replacement. And then I've already mentioned this once already, but did you get EMG studies before doing a carpal tunnel release, or did you just kind of base it on, yeah, I think the patient was a little numb in the median nerve distribution, and then you did it? So back up everything you're doing and make sure that if somebody grills you and asks this particular question, is this surgery indicated? If you did a total hip replacement on a displaced femoral neck fracture in a 35-year-old, you better have strong literature support, and you better be ready to answer that question of why you did a total hip replacement instead of ORIF in that patient. Steer clear of controversial cases, revisions for metal hypersensitivity, et cetera. That's an example in the joints world. Remember, you may believe that metal hypersensitivity is an absolute diagnosis and is something that is real, and your fellowship trained you on getting a patch test and then revising all these patients. But the person on the other side of the table, you don't know who you're going to get, and it could be anybody across the 50 states, and sometimes regional differences and just training differences in general. You better be able to defend based on the current literature why you did a surgery, and that examiner may not agree with you. Just because your attendings did something in fellowship doesn't mean that it was indicated necessarily. So here's a rubric again, and surgical indications are very important. So if you're putting nails in every compression sided femoral neck stress fracture without having tried or discussed non-surgical treatment options, they may come at you and say, is that indicated? Is that surgery indicated? Or if somebody comes in with Kellgren-Lawrence grade 1 or 2, and you did a total knee replacement on them, you're going to really have to sit there and defend why you did the surgery. So I would ask yourself when you book each case during case collections and say, is this surgery indicated? Is this a case that I could present in front of the academy on a big podium and say, patient presented with this, I discussed X, Y, and Z, and then we did procedure Z. Not all surgery is urgent. So again, you want to be busy when you come out of fellowship, but remember to optimize the patient. Optimize the patient. It doesn't really apply in the trauma situation. It can apply in some trauma scenarios. If a 86-year-old lady came in and is in DKA and has an intertroch fracture, then you probably should have a note in there that says hospital medicine saw the patient. They discussed the risks and benefits. They optimized the patient and controlled the patient's blood sugar, and then we went to the OR. If you just rush them to the OR because that was most convenient for you, and then they have a complication, you have to defend why you did what you did. So, and especially in the elective situation, so many times I've helped folks now review cases, and they develop a complication that is preventable. And so, for example, here's a scenario. So you did a triceps repair on a patient with diabetes that then got infected. Yes, sir, I did. Did you not check an A1C level on this patient prior to doing the surgery? No, sir, I didn't. So why wasn't it checked? Are you not aware that poorly controlled diabetes is a risk factor for infection? So now when this patient goes on to have some sort of allograft reconstruction, you're sitting there in front of the board having to defend why you didn't do a simple test on a patient. My advice from this slide is not all surgery is emergent. Optimize the patient, look for modifiable risk factors, and make yourself look like a good surgeon that does indicated surgery. The next document that they're going to really look at is your operative report. Okay, in this operative report, dictate your indications, dictate other details that make you look like a thoughtful surgeon, estimated blood loss, tourniquet time, and then any complications, as well as your thought process. So there is a section on the rubric that looks for complications, but it also says were the complications recognized and addressed. So putting this in your operative report is an excellent place, because when they say, oh, well, You had a periprosthetic fracture intra-op. Did you recognize it? And you say, yeah, I did. If you look at my op report, for example, at the time of placing a short nail, I noticed a cortical disruption distally. Biplanar fluoroscopy was used to confirm the fracture. I then removed the short nail and recognized that I needed to bypass the new fracture. At this point, I did X, Y, and Z. So that shows your thought process to them clearly, and they look at you and say, okay, well, this guy knows when he's in trouble and can get himself out. Or sometimes you can't get yourself out, and then you say, given the difficulty I was having obtaining reduction, I asked for my senior partner X to help scrub in with me. This demonstrates safety to the board. Just position yourself on the examiner side of the table and say, they want to look at you and say, if this guy got into trouble, what is he going to do? Is he just going to keep pressing ahead, or did he just leave the OR and say, well, we'll just kind of accept this thing, and you put the patient at risk that way. Also, please examine your patient's post-op and document this thing. Just play it forward, right? If you did some sort of surgery, let's use arthroplasty as an example. Let's say you did a total hip on a patient, and then post-op day 2, if they're still in the hospital, they develop a DVT. Imagine yourself, they're going to want to know, did you examine this patient post-op? Did they have SCDs on? Were they mobilizing? What was the DVT prophylaxis that you put them on? And so if you have a post-op note where you went and saw the patient and said, I discussed the surgery with the patient, we reviewed radiographs, the patient was mobilizing with a walker. I stressed the importance of aspirin, and we did place the patient on aspirin for DVT prophylaxis, and the patient had SCDs on when in bed on post-op day 1. You can lean on all those things going forward, because you don't know which complication you're going to develop on a patient. And so it's always important to be safe ahead of time and document and examine people post-op. Imaging during case collection period, be diligent about collecting x-rays preoperatively. So when they show up in your clinic, just don't settle for a poor AP x-ray of the elbow, and make sure you get the appropriate views that are well shot, and then also focus on saving your intraoperative imaging if your cases call for it. Some cases don't call for intraoperative imaging, but make sure you save all those views. Some of the folks over at the VA are having issues with their imaging saving systems. Please do your best to collect this stuff, because imagine showing up in Chicago where 8 out of your 12 cases don't have appropriate imaging. I think this is, at the least, is very frustrating to the examiners. Poorly shot x-rays or not having x-rays. For example, they'll say, hey, where is the lateral on this elbow? Well, I had it. It wasn't, or maybe we took it, is not a good answer. And then where, for example, where are the full length x-rays on this intertrope femur fracture that you took to the OR? That's not going to make you look ideal if you just have a AP of the hip and say, well, we did it based on this. Also, Pearl, as you can have photographs presented during your cases. This is a helpful strategy for some cases. For example, where I had that lady with a BMI that was very high, and she had draining sinuses everywhere along her lateral thigh. I did present photographs, and this is helpful to demonstrate to the board examiners the type of complexity that you're taking on. Have long-term follow-up. So if you did a surgery on a patient, you better have long-term follow-up. Or documentation as to why there is no follow-up. Have a system to track your patients when they fall off your schedule. So, for example, you're going to be busy in your practice in your first year, and you're going to be taking call, and the transfer center may be calling you, and then you did a distal radius fracture, and they were supposed to follow up 6 weeks later, but 6 weeks later in your clinic, you're overwhelmed with 5 different things, and then that patient just falls off your schedule, and it turns out you lost track. And then come the following year, that case gets pulled for your case collections. And then they say, well, you don't even have any follow-up on this patient. So all this to say, develop a system during your case collection period to say, hey, I operated on this patient. Did they come back to come back and see me? And if not, I need to reach out to them. So how do you reach out? I document something in the chart. I personally contacted the patient at phone number XYZ. I left a message reiterating the importance of follow-up. I also called the patient's emergency contact number at phone number Y and Z, and I also left a message. I had a partner who used to send certified letters to patients when they didn't show up. Whatever your method is, my advice from this slide is have a system to track your patients so that they don't fall off. And then make an effort to contact patients, whether it's telephone or certified mail or what have you, and then make sure you document that as well. It makes you look like a surgeon who really cares about seeing your patients back. And then see your patients back in a reasonable amount of time. That differs for each type of surgery, but nonetheless, seeing patients back sooner and more often, certainly if there's a complication, makes you look like a surgeon that, again, cares. Versus, for example, if you say, well, I saw the patient back after a pilon fracture that I fixed. I saw them back at 10 days. The wound was a little bit red. I put them on PO antibiotics. And then your next follow-up is 5 months later when they're totally infected. That shows poor follow-up, because they'll easily stop you and say, wait a minute, you put somebody on PO antibiotics and then you didn't follow them back up to see if your intervention had made a difference. So if you're intervening on a patient, certainly please see them back sooner rather than later. And you are graded on this. So outcomes all the way on the left show that an attempt for continuity of care is established above the expected level. Also, if you can collect outcome measures, I think it's helpful that you can say, hey, the patient's the Coos Jr. At his 6-month follow-up was X, Y, and Z. That makes you look like a surgeon that cares, and is an objective way of showing your outcomes to the board as well. This slide, the purpose here is maintain a cordial relationship in your community. I'm going to move my video screen out of the way. Okay. Maintain a cordial relationship in the community, because why? Well, the board's going to send a peer review letter to various people in the community. So what does that mean? They're going to send letters to other orthopedic surgeons in your area that are not part of your practice. So if you've been kind of a jerk to people or unprofessional, then that may show up in your peer review process. The hospital administration at your particular hospital, nurse administration, chief of anesthesia, those people also have to send back a peer review, a letter to the ABOS. So if you've been, you have engaged in poor behavior, that's going to show up as well. So please maintain a respectful relationship in your community and in your particular hospital. I get a question about this from time to time. Are you judged on your technical skill? Now, you are judged on your technical skill. So don't take on cases that you don't have the skill to see through to the other side, because they can easily stop you and say, wait a minute, you totally botched this case. Or they probably won't say that, they're thinking that, but they'll say, were you the best surgeon to take on this particular case? So if I am not particularly good at doing ACLs, if I did an ACL case and I don't even know where to drill those tunnels, but if I did, they would say, hey, are you the best surgeon to be taking on this type of case? And so you don't have to be the best surgeon in the world, but you can't be an incompetent one either. So, for example, having a calcar crack, I've already mentioned this, is acceptable, but placing a stem outside the femur is way less acceptable. That just shows that you don't have that skill set and you're taking on cases that you shouldn't be taking on. They're going to have you come back probably the following year. So when you do have a complication, step one is to recognize it. Say intraoperatively, I noticed that the tibia was moving independent of the femur. And then as a result of this, I brought in fluoroscopy, recognized that there was a distal femur fracture. Therefore, then I extended the incision, placed a distal femoral locking plate on. So step one is recognize it, and step two is treat it. A word here on preoperative planning as well. If you look at the rubric, it says preoperative planning is at the expected level. So for folks that are in the arthroplasty world or using any type of implants, having x-rays where you've templated this stuff ahead of time certainly makes you look like a thoughtful surgeon. It's helpful. I did upload x-rays of templated hips and knees and so on. Be careful with how you're billing as well. Operative reports are a window into your billing practices. So if you're doing some shady billing, like billing for bone biopsies for a primary total knee or a total hip, they're going to stop you and say, wait a minute, what is this billing about? So you better have a reason for it. Ethics and professionalism is graded. You're going to report on complications for all your cases, right? I've already mentioned this at the beginning. So if you're in your case collections, you've done 100 cases and 30 of them have complications. Chances are the board is going to look at those 30 closely and then pull your 12 from a combination of the 100, but likely it'll come from your 30 that had complications. So it's up to you which complications you want to report. Sometimes folks want to game the system and over-report complications. So, right. So if you did 100 cases and then you want to report 50 complications to dilute out all the complications. And let me explain that a little bit better. Let's say you had 100 cases that you did between April and October. One of them had a death. Another one had some nerve femoral nerve injury. Another one had an iliac vein injury. Those are three significant complications. So when you put 3 out of 100 had complications, chances are the board's going to pull those 3. So some folks have tried this strategy in the past where they're going to over-report every complication. So every lateral femoral cutaneous nerve palsy is going to get reported as a complication. And then now you have 30 complications. And so out of those 30 complications, the board's going to pick 12. And chances of them picking a horrendous complication is less because you've diluted out your complication pool with less serious complications. Some folks have tried this strategy. I will tell you, the board hand picks the cases. So there's a human driven process. It'll look at the complications you've submitted and it'll pull the cases that are more severe. So report any complication that you think is significant. But if you over-report complications, the board will see that as well and bypass your strategy. Here's a list of all my complications that went to the board. And then from this, they picked the 12 cases that they wanted to pick. After you submit your entire case list, which is 100, 150 cases or whatever you did, at the minimum, you should have done a number of 35. Then in the spring of your test year, so 2 years after you started practice, you're going to get a list of 12 cases. If there's a case on that is not representative of your practice, you can call the ABOS and see if they will switch it. In the past, I have seen the board switch cases that are not representative of somebody's practice. Chances are they're going to select cases that have had complications, so be ready for those. Preparing your 12 cases. As soon as you get your list of 12 patients, immediately call all of them back into your office because this is going to help your length of follow-up. If they can't come in physically, they've moved states or what have you, attempt some sort of remote visit, a telemedicine visit, a phone call visit, any type of visit where you've established continuity with the patient and document this. This can count as your follow-up. When you submit your 12 cases, you have to do one of the following. You don't have to do both. You have to do one of them. You have to black out all patient identifiers, and the board has a list of which identifiers those are. It's usually just the names of the patients. You can from each of your documents, and that can be a fairly tedious process. So this takes time. So make sure that as soon as you get your case list back, you start working on this stuff and don't wait until the end of the deadline date to try to submit this. So you can either black out the patient identifiers, or you can have that patient sign a form that says you have their permission to use their name on the ABOS exam. And so the board has an example of a form you can use. This form does not need to be submitted to the board. For each of the 12 cases, you're going to have to submit these documents. Pay very close attention. So pre-op note, i.e. your clinic visit note, your day of surgery, H&P, your consent, your operative report, your post-op hospital notes, your post-op clinic visit notes. Okay. I'm going to pause this here, and I want you to look at it for a second. This part is very important. These are the notes that you're going to be graded on. All right, now that you all have had a chance to look at that, I'm going to go through each of these individually. Important things to note here, in addition to that documentation, you can also submit consult notes from other services if they are pertinent, rheumatology, infectious disease, etc. And you can also submit reports of MRIs and CTs, any sort of advanced imaging that you've gotten. And then you can also submit pathology lab reports, right? So if you took somebody to the OR for a prosthetic joint infection, ESR, CRP, D-dimer, having stuff like that is important. You will also submit imaging. So again, any pre-op x-ray, any intraoperative x-rays you've taken, and then post-op x-rays, i.e. PACU x-rays, and then any follow-up x-rays. So I saw the patient back 3 months later, 6 months later, 1 year later, those x-rays. You can also include photographs. I've already mentioned this. You can also upload MRIs, CTs, whatever helps illustrate your point for why you did what you did. Here's a important point. There will be some patients that you've done more than one surgery on. So one of those surgeries may fall in the collection window, and one of those surgeries may fall outside of that collection window. My advice here is to submit the x-rays related to that patient's care and submit all of them. You control which x-rays you actually show the board, but submitting all of them allows you the ability to show them x-rays from the first surgery or the third surgery or whichever one, should they ask you. Technically, they can't ask you because it's not in that time period. However, from personal experience, my advice is if you've operated on a patient and done multiple surgeries, so did a total hip on them, that had a dislocation, then you went back, changed the position of the cup, and then you did a third surgery because they dislocated again, and you put a constrained in, and one of those surgeries fell out of the case collection period, I uploaded those x-rays because they'll say, wait a minute, so I thought are you putting a constrained in, or what did you do here? And it just helps illustrate the story better if you have all of those x-rays from previous surgeries that you've done uploaded into the system. And when you're sitting there and they say, wait a minute, I thought, what did you do before? You can say, this was before the case collection period, but I have those x-rays here to show this is what I did. So it just helps illustrate the story better. So for example, I'm putting that here in PowerPoint in Word format. So submit more instead of less. I think that's helpful. You don't have to show all of them, but having them submitted and uploaded into their system, you can at least pull it up if a question does come up. Now, let's go through for each of the 12 cases. You're going to have to submit a document called a case summary. So after you submit the operative report, the surgical consent, pre-op and post-op clinic visit notes, and the hospital notes, as well as the x-rays, once you submit all that documentation, you're going to have to fill out this document called the case summary. Okay, the case summary is a piece of documentation that you have readily available to you on the day of the exam. So anything you put on this case summary is going to be your life raft. And the examiners will also be able to look at it. The case summary has 4 different sections on it, and I'll go through each of those sections. The first section is patient data. The next section has decision-making, the third one being procedure, and then the fourth one being the outcome. So this case summary that I have a screenshot of is one of my cases, and this shows the patient data section. So in the patient data section, it'll show the things you need to submit: patient age and gender, history of present illness, relevant past medical history, and relevant physical findings. Let me share a particular strategy that I made, and I think it's very helpful. First of all, this is not the strategy. This is just a general comment. Have a polished, clean, succinct HPI. For example, I had a 68-year-old female transferred to our tertiary care center with right groin pain and the inability to bear weight for 4 months. She had a total hip replacement 2 years ago and did well until the fall 4 months ago. And she had declined since. The original surgeon transferred her to our center for higher level of care. If you start going into, this is a 68-year-old. She has a history of a previous elbow infection that developed stiffness, and then she has 4 children and all this nonsense. The board examiners will get very frustrated very quickly because they do a lot of different exams, and chances are they've already run into a lot of good presentations before yours. And so if you're sitting there fumbling around with your HPI and it's not a clean, succinct, polished HPI, it will frustrate them. And all of a sudden they'll say, what did you do in this case? Explain, just tell me what you did. And then they've hijacked your ship out of the gate, and it may make it harder for you. So in this case, here is the strategy that I'm going to share. Having a summary statement is an excellent way to tell your examiners about your entire case in the first 10 to 15 seconds, because chances are sometimes that's all the time you end up getting before they start asking you a lot of questions. So what is a summary statement? Summary statement basically illustrates the salient points of a case and what you did. And there's no section for a summary statement. So what I did was at the HPI, at the end of my regular HPI, I put a couple dashes and I wrote my summary statement in. So for example, if you look on the HPI there, on the 4th line down, I have some dashes and I wrote out my summary statement. And this summary statement is what I gave them as soon as they said, okay, go. And so I said, this is a 68-year-old female transferred to our tertiary care center for near pelvic discontinuity. Intraoperatively at the time of her revision, I encountered white fluid. Metallosis and infection were on my differential, so I treated her with a single-stage exchange and had an intraoperative greater trochanter fracture, which I plated. Patient did not have any further complications. At this point, you can then say in more detail, this is a 68-year-old female transferred to our tertiary care center, and then start with your HPI. This I felt was a very helpful strategy because this told the examiners exactly what my case was going to be about, and they weren't sitting there trying to guess which way I was going to lead them, and it helped them queue up their questions for what they were going to ask me. So they knew they were going to ask me questions about how to diagnose infection or metallosis or whatever. I highly recommend having a summary statement, and I highly recommend you writing it out at the bottom of your HPI so that you can lean on it as soon as these two examiners are staring you in the face. The next section on this stuff, on the patient data section, is relevant physical findings and relevant past medical history. Don't sit there and talk about patient didn't have any lymphadenopathy and the patients had regular rate and rhythm and all this stuff. That's not really relevant to you having done a hip revision, unless they had some cardiac event, which that's different. But in a setting of metallosis, that stuff is not relevant. If they ask you, you should be able to say, well, yes, I did yes, the patient does have hypothyroidism or whatever, but write down only stuff that you think is relevant. So for example, in the past medical history, I said she has a history of obesity, and I used the notation system of parentheses, the square parentheses and the circle parentheses. So anything I put in a circle parentheses, I told myself I'm going to share this information voluntarily. Anything in the square parentheses, I said I am not going to share this information voluntarily, but if they ask me, I have it ready. So for example, here's what I said. She had a history of obesity with a BMI of 37. She had sarcoidosis, not on any immunosuppressives, and paroxysmal supraventricular tachycardia that was medically managed, and she had a normal cardiac workup prior to transfer. Okay, if they stop me and say, "Wait a minute, this case was a possible infection case. She had sarcoidosis. Was she taking prednisone?" Then I can say, intermittently she took prednisone, but she had recent pulmonary function tests which were within normal limits, and so therefore she wasn't taking any prednisone anymore. And so I had this notation system of open and closed parentheses to share information that I wanted to, and have information queued up, but not shared in the square parentheses should they ask me. Your examiners are going to see this document too, so it's full of typos and doesn't make any sense. Just makes you look poor, but chances are your examiners are going to be sifting through your documentation as far as consents, operative reports, and so on. So if you have a typo or two on this stuff, it's not the end of the world. this is your script. Again, this is what you're going to have in front of you. This is your lifeline. So I suggest you make a well-crafted summary. You put it at the bottom of your HPI, and you lead with that statement. It's a summary statement. It'll help you organize your thoughts. It'll help your examiners organize what they're going to ask you too. The next section is decision making. So interpretation of laboratory and imaging studies. There's a section for that. There's a section for diagnosis, treatment plan, and primary surgical indications. Again, the indications show up. When I presented this section, in addition to the obvious stuff up top, I said my indication here was hip pain and the inability to ambulate in the setting of a periprosthetic acetabular fracture. So it's a strong indication. They can't fault you for that. I'll leave this up here that you guys can look through this. And again, my square parentheses were a system of information that I did not volunteer but had available should they ask me. So I said pre-op biomarkers were normal. Then I moved to AP and Judeo-pelvic radiographs, et cetera, showed whatever. But if they say, wait a minute, what biomarkers are you talking about? I'd say ESR and CRP were normal. ESR was 8, high normal 30. CRP was 0.2, high normal 1 milligram per deciliter. Know your units as well, because sometimes it could be milligrams per deciliter or milligrams per liter, and that makes a difference. Next section on your case summary is going to be your procedure. So again, you are going to, on your day of the exam, you're going to walk through this case summary. You're going to say, you're going to start with your patient age and gender, keep working your way down, and you're going to get down to procedure. And you're going to be, what I did was I read off of this thing. I still made eye contact with the examiners, but I was reading off of this, and having the square parentheses and the open parentheses was very helpful. Other pieces of information the board's going to want to know are length of surgery, your estimated blood loss, and your post-op course. So, and then look at the bottom. It says total length of follow-up. So if you just have 2 weeks as your total length of follow-up, it's going to make you look pretty poor. So I'm presenting this to you guys. Hopefully, if you haven't started practice yet, you can say, well, these are the things the board looks for. If I'm in there for 5 hours on a case, the board's going to know that. Or if I've lost 2 liters on a shoulder replacement, they're going to want to know what's happening. That's a metric that they look at. And then finally, in the case summary, there would be an outcome section. The questions that you may get asked are, is the patient happy with the outcome? Are you happy with the outcome? Were there complications? If yes, what was your response? And then what would you do different next time? What went well in this case, and what might you do differently? So this is an outcome section that they may or may not ask you about. But to present your case, again, let me just highlight the importance of this. Your presentation is what is going to let them look into your thought process, and your presentation is what they're going to judge you on. So my advice is use your case summary for your presentation. Specifically, put your case summary at the bottom of the HPI, read the case summary, then read your HPI, then read the past medical history, read the physical exam, and then read your decision-making section, and then read your procedure section. And after that, they may or may not even ask you about your outcome. Now, they may at that point take over, but that is how you give a good presentation. And once the board picks your 12 cases and you're making your case summary, and you've got all your notes ready, I would assemble your O.J. Simpson defense team. This is sort of a team that's going to help you polish your cases. And so here was my strategy that I want to share. The first important part is to pick critical and seasoned reviewers. Some people are very nice. They're your partners. They're not going to criticize you. Those people are less helpful in this case. You want to pick people that are very critical, who may or may not agree with your decision making. And pick people who genuinely are interested in helping you. If you look over and you're trying to present your case, and the mock examiner is responding to emails or whatever, you're wasting their time and they're wasting yours. So pick people that care about you and pick people that are very critical. And for each case, go through and say, what are my vulnerabilities in this case? And then after that, lean on the experts to help you polish your vulnerability. So for example, here's what I did. This was a lady that I did a primary total knee replacement on. She developed a flexion contracture post-op. and I reoperated on her, and I presented the case to one of my partners. And I told him, I said, I revised this lady for a 10-degree flexion contracture at 2 months post-op. This, if I went to Chicago with this statement, I said, I revised this lady for a 10-degree flexion contracture at 2 months post-op, there are about 10 things wrong with that. Wait a minute. What do you mean you revised her for a 10-degree flexion contracture? Is that even clinically significant? Also, you took her back at 2 months post-op. This is a setup for an absolute nightmare. So instead, I got my OJ Simpson defense team, which included a lot of folks here from Emory and other institutions, and we helped polish this up. We identified a vulnerability, said, man, you really, first of all, 10 degrees is not that much. That's one vulnerability. The other vulnerability, you took her back at 2 months. Okay. You really didn't even give her much of a long, maybe taking her back at 1 year is a little bit different. So you got to polish this up. So here's the polished version. Patient was followed closely post-op. We tried 8 weeks of physical therapy without resolution of her flexion contracture. She had a minimum of a 10-degree flexion contracture. Her radiographs showed that double bubble sign described by Dr. Arlen Hansen from the Mayo Clinic. This affected her gait significantly. She worked as a school teacher, and I did not think she could go back to standing in the classroom. I do not take revisions lightly. However, I felt that I had under-resected her distal femur, and I felt that I could help her problem surgically. That polished statement is very different than my original statement of I revised this lady for a 10-degree flexion contracture at 2 months post-op. So get your team. Here was my team. A big thank you to everybody on this list, particularly, again, Tom Bradbury, folks at Vanderbilt, and Dr. Rafael Sierra from the Mayo Clinic. Once your 12 cases are submitted, practice with as many people as you can. I did it with at least 5 people. Actually, I did it with way more than 5 people. Look at this list. Nonetheless, practice with as many people as you can. Pick critical attendings. Pick attendings that are not in your geographic area or your program. For example, me practicing with a private practice guy in Kentucky, it's very different. They don't do a one-stage exchange there. He was very critical of some of my one-stage exchange and said, hey, what's your literature here? What type of host was this, et cetera? And then sometimes pick attendings that are not even in your subspecialty. So Dira Ananthakrishnan was one of the spine attendings here at Emory, and she spent 2 weekends with me going through my cases. And she said, wait a minute, you're jumping and this makes no sense. So you revised this patient for what, or why did you do this? And so practicing with folks that are not necessarily in your subspecialty helps you polish out your presentation and helps explain gaps in your presentation. Also, you can record your presentations and then listen to them. And you'd be surprised at how often you're using filler words like, and et cetera. So just a word on presentations to work on being concise. The decision to go to courses, my advice is there another platform to help you practice your presentation. So if you have folks that are, if you really don't have any friends or anybody to help review your cases with you, these courses, the Miller Review at least was helpful for me in the way that it introduced me to folks that were critical and that would listen to my presentation and give me feedback on my particular case. I didn't do the main review course. I can't comment on that. For each case, I wrote out as many questions as I could think about. So patient, I said, patient had tried non-operative management. And then I immediately wrote a examiner question right underneath it. What non-operative management? And then I would write my answer. Tylenol, tramadol, et cetera. And then immediately fire back with what the examiner would ask me. What is the mechanism of action of Tylenol? It works via peroxidase inhibitor or whatever it is. You write that. Then what else did they try? Tramadol. What does the academy say about using tramadol? So I wrote out close to 100 questions for each case that I could think about and anything that could fire on me for. It could be something as simple as what's the mechanism of action of TXA, all the way to describe the geometry of your bearing surface here. Is this a medial congruent or I'm using a lot of arthroplasty examples, but they may ask you, hey, what's your working length on this ORIF of your distal femur? What's the working length of this plate? And is this titanium plate or is this a stainless steel? And what's the data say about using those two different types of metals for this plate? So be very critical and write question upon question upon question and give answers. And then whatever question you end up writing, like for example, what non-operative management, and you write Tylenol, then be ready, because anything that comes out of your mouth is open to fire. So they'll say, what do you mean Tylenol? So Tylenol what? So what does the data say about Tylenol, et cetera? And then read at least 2 to 3 pertinent cases. That's sort of a general statement, I think, as you're preparing and you recognize, well, shoot, I don't know what the Academy says about tramadol. You're probably going to read an article on that anyway. Review the guidelines put out by the Academy, and then subspecialty groups as well, POSNA, OTA, et cetera. Let's go next to the day of the exam itself. Some things are obvious. I would highly encourage you not to fly in on the day of the exam. That's obvious. You guys are all smart. Bringing your exam clothes with you on the plane as opposed to checking them in can be helpful. For the folks that are very athletic and like to clear their head, there is a gym and a pool in the Palmer House. There's a Starbucks on the first floor. Interesting, when my second go around, it wasn't even, they actually weren't working that day. And so then there is a Dunkin' Donuts around the corner. So there's coffee there. Appearance matters, so they don't know you from anybody else in the world. I typically don't shave. I hate shaving. But you better bet for this exam, that was about as clean shaven as it gets. Make eye contact with them, and sir and ma'am, we're here down in the South. That's a no-brainer for us, but some of these examiners are that way too, and they're old school. Be very respectful. They want to feel important. Let them feel important. The format of the exam is you're going to present all of your 12 cases in order. In the past, you could present them out of order, because an examiner could come in and say, show me your best case, or show me your worst case, or what case did you have some trouble with that you want to discuss with me? But now they say, okay, case 1, 2, 3 first, then 3, 4, 5, or excuse me, 4, 5, 6, and then 7, 8, 9. It goes in order. You get it. You have 2 to 3 minutes between the blocks. So here's, the first block is case 1, 2, and 3. You're going to have 2 examiners. And then the next block, and between the blocks, you'll have a couple of minutes as they're moving, and you are staying seated in your chair in the booth. There's no material in there, by the way. No, anything you bring from the outside, you can't use it here. So the only thing you really need to have is a form of identification with you. So some license or a passport. Examiners don't give you any feedback. So as humans, we're used to getting some feedback, saying, oh yeah, I put this plate here and the screws are aimed a little bit posterior. And then your attendings usually say, yeah, well, not the worst. But here, these people have ice in their veins. They're looking right at you. They say nothing as far as feedback. They fire question on question on question, and they'll cut you off at any point. So here's the format about where you're sitting. You're sitting on one side of the table. The two examiners are sitting across from you. Everybody's got a laptop, and they can all look at your documents. And then you have a mouse that controls what you show on the screen. So there's a screen at the end of the table that you control, and you can put up your x-rays there. Okay. A word on that: leave x-rays up that you are proud of for each case. So if you have a great post-op x-ray, go through the case and leave that x-ray, the post-op x-ray up. If your intra-op x-ray was awful, where it was rotated and you broke something, or you reamed through the acetabulum or whatever, don't leave that x-ray up. I think when they're sitting there talking to you, they're going to look at that screen naturally. So a tip is, don't leave x-rays that are helpful and you're proud of up on the screen, as opposed to the reverse. Be ready to answer questions on your entire case list. So if you submitted 100 cases, or you did 100 cases between April and October, an examiner may come in there and say, oh, well, you had 29 superficial infections submitted. What is that about? They're not going to ask you about particular cases that were not the 12 selected, but they'll ask you about general trends, because they have a little chart in front of them that shows them what general trends you had. Your average follow-up was 3 weeks for your patients. What's your follow-up protocol with patients? So this is in the couple of minutes before they start asking you about your particular case. They may ask you generalized questions. Say, how busy is your practice? How often are you taking call, etc. The other thing is, now the ABOS now records. There's a microphone in there. So if you really feel that an examiner has sat there and derailed you, hasn't let you talk, etc., or has given you biased or unfair treatment, then these recordings now are going to help you. I am very proud to say that this was one of the things that I went back and forth with the board on. They now, at least this helps distribute the power structure a little bit better so that you're not as vulnerable as you have been in the past. In the 2 to 3 minutes before the exam actually starts, they may, like I said, they may ask you those generalized questions. Who's your chairman? Tell me about your practice. And this is my advice. I did it both ways, but I think the second time it worked out better for me. When I did strike up a conversation with them, this is a time to sell yourself. I work at a level 1 academic center where I was hired as the revision guy in our practice. I'm the only guy that does hand surgery for a 30-mile radius or whatever. And so talk to them about themselves too. It humanizes the test a little bit, and there's no rule against this. I think the first time I went, I didn't say anything. And I think it was a very sterile type exam, which I don't think worked in my favor. I think the second time I went, I asked them about themselves. Oh, I don't think there's anything wrong with that. It humanizes them, and ultimately you want them on your side. I've already mentioned this. When presenting your cases, as soon as the bell rings, they say, okay, ding, 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 go ahead and go. Hit them with your summary statement first. So I present a 72-year-old female that I did a primary total hip on. Intraoperatively, she had a calcar fracture, which was treated with cerclage wires. She did not have any further complications. And then you go into your HPI because you're going to be looking right at your case summary. More specifically, this is a 72-year-old female. And then you launch into that. For more complicated cases, your summary statement's going to be a little bit more detailed, but still keep it concise. So this summary statement, this is a 54-year-old female who presented with a loose acetabular component in the setting of metallosis. I revised her acetabular component. Post-op, she had a fall, fractured her greater trochanter, and had a dislocation that I treated with ORIF and open reduction. She did not have any further complications. Again, the purpose of this slide is to say polish and develop a nice summary statement and tack it at the bottom of your HPI and your case summary so that you can use it and hit them with it as soon as the exam starts. Common helpful terms when giving this exam. My thought process here was, you use this statement to help them and help you form your answers as well. So instead of saying something like patient presented 8 weeks later with a 30-degree flexion contracture and we took her back for an MUA, it should be framed more like this. Framing is very important. Patient presented 8 weeks later with a 30-degree flexion contracture. My thought process at the time was she had full extension preoperatively. She had diligently done physical therapy. Her pain medication regimen was adequate. And I felt that because her gait was so limited, we could help her with an MUA. Using that statement, my thought process here was peppering it in appropriately will help you frame your answers and help them assess what your thought process is, because ultimately that's what they're trying to do. Using the statement, I was aware. So when consenting this patient with rheumatoid arthritis for a total knee replacement, I was aware of the increased risk of a PJI and wound complications. I was aware of the ABOS and American College of Rheumatology guidelines for stopping her biologic medications. And based on her prior history of an MRSA after elbow resektomy, I understood she was high risk for prosthetic joint infection. Based on this, I placed her on 2 weeks of PO antibiotics post-op. So using statements like I was aware lets them know that you know what the pertinent points of the case were. I cited literature, but how you cite it is important. If you cite it appropriately and you're humble about it, it's well received. So I said I am not an expert in the literature, but based on my reading, I knew that hip abduction pillows do not reduce the risk of redislocation. And you can cite literature, be humble about it. And sometimes you can bring it up in this way. I read the paper by Dr. Yu, which showed equivalent outcomes of a 1 and 2 stage exchange for hip PJI. And based on that, I did a 1-stage exchange. But as soon as you cite literature, you better be ready to back it up, because they may say, wait a minute, was that a level 5 editorial, or was this really a randomized prospective trial? And if you're sitting there and you don't know, or you're BSing it, they're going to catch on. Obvious things are obvious. Don't lie. It's obvious when you do it. If you don't believe me, sit down with a person that's going through the exam the same cycle as you and have them give a presentation. If that person's a BSer, you're going to be able to recognize that pretty quickly, because they'll show you an x-ray. You'll say, well, did this patient have good intraoperative balance medially and laterally? And you've got an x-ray that clearly shows a laterally gapped joint space. And they look at you and say, yeah, I did a intraoperative exam at 30 and 90 and it was stable. You're not stupid, and neither are your examiners. So, and they've been doing this a long time. So when the answer is false, or if you don't know it, just say you don't know. I'm sorry, sir, I'm not sure about that. And this is only going to work for so many of their questions, because if they ask you 30 questions and the answer to 20 of them was, I'm sorry, I don't know, you can imagine where that's going to go. Also, use Control F if you're flustered and you're trying to find something in your documentation. That's just a Adobe Acrobat trick. If they say, hey, did you use 2 grams or 3 grams of ANSF here? Instead of fumbling through your 60 pages, just Control F. Also, it's important to stay succinct and answer the questions they ask you, but that doesn't mean you just give them 4 words. That's it. For example, in this case, this was a case that I had my second cycle. For example, again, this is a hypothetical scenario, not an actual question I was asked, but based on my experience, I want to impart to you an important teaching point. For example, if an examiner asked me, did you not get a CTA of the pelvis here? Instead of me saying, no, I didn't, a better answer is, I did not get a CTA in this case. I typically do think about CTAs in cases of hip protrusio or when there's significant medial bone loss. And because this case did not have that, I did not get one. And now, having learned that I have now learned that getting a CTA in cases of extensive hardware and infection is important. So I think it still answers their question of, did you get a CTA of the pelvis here? But it at least helps you justify your thought process, versus if you just said, if this is a case where there was an iliac vein injury, and there was in this case, then if they say, you didn't get a CTA of the pelvis here, and you say, no, I didn't, that makes you look either careless or arrogant or whatever. And if you give a more detailed answer, yeah, you're being a little more wordy, but you're explaining your thought process. You're saying, I didn't get it here, I get it in these cases. That demonstrates that you're a safe surgeon and you do have a role for CTA, and then that you've also learned. So it's okay to admit that, I've learned from this case that I would get a CTA in the future. This is what shot me down my first go around. If you get flustered, and all of us are surgeons, most of us are very confident people. But when you get into this room of 2 people who don't know you and they're firing on you question after question after question, it's possible to get flustered. And getting flustered is like you are in a helicopter and somebody fires a rocket on you. And as soon as you're hit, this thing's going down. So be careful with your emotion and be diplomatic. Don't get angry. If you feel like you're getting flustered, it's okay to say, I don't think what I'm trying to get across actually got across. Is it okay if I re-explain this? And you can use that statement to help you reset. Some examiners may inadvertently or purposely try to jostle you around, and they say, hey, you did a anterior approach here. Do you think it's better? And so instead of just saying, yeah, it's better, or to answer that question diplomatically, you can say something like, I don't always think one's better than the other. I think there are several advantages. There are several different approaches to the hip, and there are some advantages to one versus the other. For example, this patient is Parkinson's and bedbound, and I did a anterior approach here to minimize my risk of dislocation. That being said, you have to be ready to defend anything that comes out of your mouth, because they may say, what are the advantages of the anterior approach then in a patient with Parkinson's? Also, it's okay to politely stick to your answer. If they say, hey, is this a false profile view? And you say, yes. And then they say, well, how do you shoot the false profile view? And you say, oh, well, you get them positioned up against the board and the beam rotates 30 degrees. If you know whatever angle it is, then stick to your answer. And they may try to jostle you. They'll say, is it 30 degrees of external rotation or 80 degrees? And is it 30 or 80? Which one is it? And so if you know for a fact that it's whatever answer it is, then stick to your guns. It's okay to do it, but do it politely. Don't overshare. Here's an example of somebody who had failed a previous cycle I had a chance to talk to. And how did you reduce the Vancouver C fracture? A good answer, in my estimation, is this. I reduced it using traction and rotation and provisionally secured it with a cerclage wire. Here's an example of somebody oversharing that got him in trouble. I reduced it with a cerclage wire. I had to make a much bigger incision, and in the process, I beat up vastus lateralis, and then she kept draining for 3 weeks post-op after that, and then she didn't come back to my clinic. And then that's all. That is not false information. It's just not necessary to answer that question. One surgeon that had failed later told me that he had to hire a coach, and the coach told him he had a deep desire to always confess. I'm not telling you to lie on this exam. Again, if you notice up top, how did you reduce this fracture? And that's my answer. I just don't overshare. I've already mentioned what you leave on the screen at the time you're talking can impact the examiners. So if you've got an x-ray that you're not proud of, move past that x-ray quickly. Don't leave it up on the screen. Also, don't jump from image to image in rapid fire because it may just make you look very disorganized. Also, you can split the screen and show 2 images at once that are up there. So, for example, I had a case where the case that got selected was a total hip replacement that got sent to me. It had a prosthetic joint infection, and I revised it. And I had multiple complications getting to the revision, and the final result was appropriate, and the patient was happy. But I had some complications along the way. So at the very beginning, I put on the left side, I put my pre-op X-ray, and I put my post-op X-ray, the very last follow-up X-ray, all the way on the right side of the screen. And I said, in my summary statement, I said patient ultimately had a good result, and I did have some complications along the way. And then they versus if I had not done that, I don't know that the examiners would have been resting easy. I would have been telling them the story about my first complication, my second one, my third one, and they would have been like, oh my God, what is this guy doing? Anyway, after the exam, there's an appeal process. If you want to do this, you have to do it immediately. Go back up, talk to the executive director of the board at the time, or the president, or somebody who's up there in that main room. Once you leave the Palmer House, there's no appeal. You could be absolutely right in your case, but there's no appeal after that. So when you get your letter, this was my first letter, the one that I got. It'll be 6 to 8 weeks after you took your exam. If you unfortunately do fail, it's going to be a challenging year ahead. Remember, mentally challenging. There's a lot of second guessing, and it feels embarrassing. My advice here is find a support network first of family and then mentors that can boost your confidence. Discuss it with your chairman and leadership at the hospital, and restrict volume for complicated cases, because chances are you need to focus and start on square one and start with very easy cases and not take on as much complexity, because that may have contributed to part of your problem. And then schedule a phone appointment with the ABOS. In my personal experience, this was not as helpful. And they may give you some generic feedback about, well, your consents maybe weren't great or whatever, but they will, the answer that I got was, we are an educational body, and that we are not an educational body, we're a certifying body. So the feedback there is not going to be as satisfying as you think. And then remember, I've been there. You can reach out to me. When I got this letter, I didn't know about anybody who had been in this boat, except with the exception of one person. That's partly why I give this talk. Remember, you have 5 years from the end of fellowship to take this exam. The ABOS is going to allow you to retroactively collect. Again, going back to my first point, until you have that letter that you've actually passed part 2, don't think you are out of collections. That's what I'm saying there. My advice is, it's not, God forbid, if you do fail, it's not necessarily a reflection of you as a surgeon. You don't lose your job. Most places will not strip you of your job just because you haven't had a board certification yet. And if you're struggling, you can always email me. That's my first name last name @emory.edu. By the way, I never mentioned this, but somebody asked me this after I'd given this talk once. I did pass, by the way, the second time. So anyway, big thank you to my partners. A particular shout out to Tom Bradbury. What I want to say about him is he's one of those once in a lifetime kind of people that you're going to meet. If you haven't met him, or please get a chance to say hello to him at a meeting or something like that. He's a guy that was my close mentor, my life raft, and really helped me get back on the horse after this experience. He's a guy you're going to kind of meet once in your life, and so I can't say enough good things about him. The rest of my division is up there as well: Dr. Robertson, Dr. Gal, Aarons, and then certainly on the home front, which is just as important, having your support network. My girlfriend and my German Shepherd, both of them were very instrumental in helping me, and still are. They tolerate me giving these talks and taking time away from the family side. Finally, thank you to all my countless mentors, Vanderbilt, Pittsburgh, and Missouri here at Emory. And then thank you to you guys as well for taking time out to listen to this talk. Thanks. And if you do have any questions or concerns, comments, etc., don't hesitate to reach out and send me an email.